Insurance Services Division, and UPMC Enterprises. That's University of Pittsburgh Medical Center. And UPMC Enterprises, for those who don't know, is probably one of the most innovative, if not the most innovative, incubation hub for advanced analytics and startups, and a whole ecosystem of companies in the health IT and analytics space that are doing new things around predictive modeling, statistical analysis, applying machine learning in various ways, and Pamela Peele is a key leader in that effort. She also knows where a lot of us are coming from, as she was formerly Vice Chair of the Department of Health Policy and Management at the University of Pittsburgh Graduate School, and she currently holds appointments at the School of Public Health and School of Medicine, University of Pittsburgh, and is a core faculty member of the Center for Research on Healthcare at the University of Pittsburgh Medical Center. She's published numerous articles and book chapters. And interestingly, IBM chose her as the first IBM Big Data Hero. And 2014 was IT News Minimum of the Year as a top innovator in healthcare analytics. And I've had the pleasure to see her speak before, so I know you'll really enjoy Dr. Peele's comments this morning. So with that, I will invite Dr. Peele to open CHITA with her keynote.
Thank you. Thank you. Is this on? No. I think it's on. Okay. Good morning. I'm Pamela Peele. Thank you for coming. Thank you for inviting me. It's always a pleasure to be in a room full of really scary smart people, and this is a room full of scary smart people. This morning I'm going to talk to you a little bit about what we do. So I'm at UPMC. First of all, my background, I'm an economist, so I have a PhD in economics and game theory. I've been in academics, as Kenny referred to, and I went to the dark side about 13 or 14 years ago. And I've been working on the corporate side of the world while continuing to teach and have graduate students. It's been an eye-opening experience, and I'm going to show you some of what we do. So what we're going to do here this morning is I'm going to set this up with what we do around analytics and thinking with data. And yes, and thinking with data. And yes, there's a slight issue with time because this is 2019. I'm still living in 2018, I'm sorry to say, but 19's almost over, so I'm just going to skip it and go directly to 2020. So let's just start off a little bit about what we're doing. So I'm going to talk to you a little bit. We're going to be buckle your seatbelts because we're going to go quickly. I'm going to talk a little bit about what we do and how we use data and how we apply it to actual operations of running something and how we apply it to thinking. And then I'm going to go through a whole series of examples of what we do. And then at the end of that, we'll have a chance for some questions, if you have questions about what we do. Let's get going. First of all, why are we doing anything in this space? Has anybody been to Cusco? Oh, good. I mean, come on, you guys. You got to get out more, really, seriously. So this is the painting that's in the cathedral in Cusco, which is in Peru. So when the Spaniards came in and conquered the Incas, they took over their temple. They tore it down, actually. They did more than that. And then they enslaved the Incas and had them build a Catholic cathedral. The Incas are extraordinary craftsmen and always have been, artists and craftsmen. And so as they asked inside the cathedral, they had the Incas do a Last Supper, of course. Take a look at that, folks. What is that? What is on the platter? A guinea pig. The prized meat in Peru. That's no turkey, folks, that's a guinea pig. So the whole point of what we're doing here with data and why we do something with data is to consume something different. If we're not going to do something different on the back of our investment in data, then there's no sense in us doing it or thinking about it. And of course, this is what we do with data. We think the several things that it allows us to do. One, machine learning in particular, allows us to know what we haven't known. Hypothesis testing is fine, but you have to think you know something. You have to form a hypothesis. So you think you know something, so you test that hypothesis. In machine learning, we don't know what we don't know. It is really a matter of exploring the unknown and learning what we don't know. Oh, yeah. We need to talk about this. So before I go any further, in data, we are using transaction data. So if you go out to a machine learning conference or an AI conference or any type of conference where we're talking about data, people will look at us as if we are losers. Because they are gambling, I'm telling you, I was just in Vegas giving a talk, holy schmoly. First of all, there must not be any mirrors in the hotel rooms there because nobody would go out in public dressed like that if they're in a mirror in a hotel room. But nonetheless, holy schmoly, the casinos are amazing with their use of data and technology. The minute you walk in that place, they know everything about you. And they use it to figure out how to keep you in the casino and keep you gambling. It is stunning. They look at us in healthcare and go, you guys are using clunky old technology and clunky old models. What's wrong with you? There's an issue here. In healthcare, we look at data. So let's talk about this. So, Kenya walks into a store and he buys a bag of potato chips. Not that he would ever do such a thing. And he buys a bag of potato chips and he pays whatever he pays for it. It's a transaction, right? I walk in right behind him in the same store and I buy a bag of potato chips from the same manufacturer and the same lot and I pay for it. And that is a homogeneous transaction. What he did and what I did are identical and the same, and we can treat them as such in any kind of modeling or predictive modeling that we're doing. That's not true in healthcare. In healthcare, I walk into Dr. Schmo's office and see her for an ICD-250, diabetes, and I get a visit for CPT code of 99215 for an established patient follow-up. I have an interaction with Dr. Schmo, and I walk out. Kenyon walks in right after me for diagnostic reason of ICD-250, talks for however long he has an established visit for a CPT code of 99215. Something entirely different happened in those two visits. And yet we treat them as if they're homogeneous, because that's the only way we can treat them. But this is the transaction problem in data. Now, buckle your seatbelts. We're going to go through a whole series of examples of how at UPMC we use data, and then I'm going to talk to you a little bit about the Pittsburgh Health Data Alliance, which is connected to UPMC Enterprises, which is our startup and venture capital side. All right, so here's an example of one of the things that we did. We did a model. It's a lovely model. Oh my God, you've got to love this thing. It's so elegant. This model predicts the probability that you will be readmitted 30 days, any reason, before your index admission. That's what's so special about this model. We don't need to see the index admission. We predict your probability of readmission before you were ever admitted in the first place. We run this on everybody every month, and here's the distribution of the readmission predictions. And of course, we got all excited. The model works extraordinarily well. We got all excited, and we went out, and what did we do, folks? That's right. We went after all those high readmission people. And we threw resources at it. We had care transition coordinators at home, follow-up care, and what difference did it make to the readmission rate? 0, that's right. It had no impact whatsoever on the model worked well, but people were still readmitted. It took us a while, probably 18 months, to finally learn that's the wrong place to go. It is not the high readmission people. They're coming back. Let it go. There's nothing you've got to do on that. It's the people who have a lower readmission rate. So one of the ways that we use our data is, again, understanding how to go after the issues that are impactable to us. Oh, and so what did we do on the back of this? It's a little more complicated than it looks on the front side, but what we did on the back of this is we looked at the impact of an outpatient follow-up visit post-discharge for medical. These are only medical discharges, because surgical discharges, the follow-up visit is bundled into the hospital payment. So you can't actually see the follow-up visit. You can see it on medical discharges. And what we found out was, yes, follow-up in the outpatients clinics, post-discharge, matter. They matter a lot, but it's got to happen by day 6. So after day 5, we got nothing. This is one of the things. What did we do with this? We changed the way that we bonused our physicians. So one of their quality metrics is, and has been for a number of years now, 5-day follow-up. How many of their patients did they get into the clinic within 5 days of a medical discharge? So we discover from our data, and then we change our processes of the way that we do business. Oh, I love this. Oh, this is so cool. I know, you don't see anything here. I'm going to show you, pick this up. So this is DRG 470, uncomplicated joint replacement. Why did we use this? Because if we could have upcoded it, we would have upcoded it. We are masters of doing this. So these are genuinely all uncomplicated joint replacements. Now, what are you looking at? Does it have a pointer on it? Maybe. Yeah. All right. So here, in order from left to right, imaging, consulting, testing, attending. How many images, i.e. x-rays, how many images, CT scans, images were done during the inpatient admission for the uncomplicated joint replacement? The middle of the eyeball, we actually call these the eyeball charts. The middle of the eyeball is the average. The eyelashes are the confidence intervals. The size of the eyeball, which will matter here in a minute, is the readmission rate for these particular admissions. So now what are you looking at? The number of images, the number of consultings. That is, you got a cardiologist to come see the patient while they were in, you did a consult to another service while the patient was in the hospital. The number of tests you did, these are lab tests. And how many times did the attending see the patient while they were in the hospital? So you've got imaging, consulting, testing, and attending. These are hospitals. I'm going to show you a variety of hospitals here. So these are all UPMC hospitals. Oh my gosh, they're all over the place. Noisy, 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 bingo. What is going on here, looking at our data? These guys are all over the place. Tons of variation in what they do. Look at the readmission rate on this particular facility. It's so small, it's almost zero. So what did the physicians have to say about this? My patients are sicker. Not true. Not true. And in fact, the patients that are sicker are the yellows. This hospital and this hospital have sicker patients. Not true. What did we do with this? We went and found out what are these people doing. They work on an incredibly tight protocol. Every patient comes in, assigned to that protocol. They all adhere to the protocol, and look at the results that they get. What did we do on the back of this? We moved people to the protocol that was going on at this particular hospital. Nobody had any idea. If we hadn't been mucking around in the data, we would never have seen this. Oh, this is lovely, isn't it? I actually have this framed in my office. I love this. So this is how patients and facilities, patients and providers interact. So this is a model of attraction and repulsion. So what happens here is all the pink dots. See these pink dots here? All these pink dots are facilities. They're hospitals, they're nursing homes, they're home care units, they're facilities. All of the blue dots, it's a little hard to see, the blue dots are specialists, and the black dots are primary care. What's going on here? This is several years worth of data. If providers share the same patients, they pool together, they attract. If they don't share the same patients, they push apart, they repel. And so this is patients moving around among providers. What do you notice here? There's a big bolus of providers and patients that all move around together in the middle of that. This is not geographic, this is just interaction. There's a big bolus down here, highly repelled from the rest of the network of patients moving around. And there's an interesting piece up here. So what's going on here? This is actually our main academic center. What is this? Highly repelled. They don't share at all. Pediatrics. This is our pediatric hospital, our pediatric facilities, our pediatric providers. The pediatric patients do not interact into the main part of our hospital system. So they are highly repelled. See the little figure 8 going on there? That means there's something there. That's what these ghost trails are people moving. What's in the little figure 8? City of Pittsburgh, ambulance services. So when people move, when children move between here and the main academic center, they overwhelmingly do it in medical transport. That brings us to these guys on the top. It's a small group, a lot of facilities in there, repelled again, and a strong figure 8 sitting there. So when patients leave that particular group, they overwhelmingly do it in medical transport. What is it? That's Heritage Valley Health System. It's not a UPMC facility. They have their own wellness center, their own hospitals, their own home health, their own long-term care units. They keep their members, their patients inside themselves. Their patients do not go outside their particular setup and network, except when they do it, again, in medical transport. How do we use this? So I took away the facilities, and I've just left the providers here. And now I'm showing you the link of how providers share patients, or how patients move around among providers. What you see is, and then I've conveniently color-coded it for you, so you can see the direction of movement. Let's go up here to these guys. There's the blue, the yellow, and the orange. You can see that they don't play with the rest of the providers. They're not there at all. And these yellow people refer down to these red people, and the blue people refer back and forth. If you take any one of those providers out, you just made a dysfunctional network. So as a payer, as an insurer, if we come in and want to talk about tiering our network, or how are we going to arrange our network, if we don't understand how the network actually functions, we could come in and do all kinds of stupid things and take these little red guys out of the high-tiered network. Now I've just disrupted a huge referral mechanism in here. So this is how we learn what is going on and change the way that we do things. I like this because I'll put it up quickly, because these are 3 different hospitals. They're fairly rural hospitals, and they will all tell you that their patients don't go anywhere outside their hospital. They'd be wrong. They are wrong. They are wrong. They are wrong. Again, these are providers. These providers overwhelmingly use either hospital A, B, or C, and you can see that the providers stay pretty tight to the hospital that they use, except for hospital B. Isn't that interesting? Hospital B has 2 distinct cliques of providers. These providers who overwhelmingly interact with hospital A when their patients move, and these providers who overwhelmingly interact with hospital C. And the only thing that keeps the hospital B's providers anywhere, these 2 providers, anywhere near each other, are those 3 dots in the middle between them. So if those 3 dots in the middle, right here, didn't exist, those 2 provider groups at hospital B would explode apart. And you would have 2 distinct groups, here and here, and here and here. Who are the 3 doctors in the middle? The only 3 radiologists in the county. So it is the radiologists that hold this particular group together. Oh, love this too. So here's an interesting little setup. I'm going to show you the topology of chronic disease in Western Pennsylvania. So you're looking at a map of Western Pennsylvania. Here's what we do. We make each person as tall as their stack of chronic diseases. We threw out hypertension and high cholesterol because they're just scalars. Now I've got 31 different chronic diseases. Each person is as tall as your chronic diseases. We geocode everybody. So, and we keep huge registries. Our data set under this is like delightful. So now I can put each person on the map where they live, because I've got your latitude and longitude. So we place each person on the map where you live. You're as tall on this map as your stack of chronic diseases. Now you have to smooth it a little bit. So we use a kernel density estimator here to kind of smooth it out a little bit. Now I've got a cube. I've got a map. I've got people standing on the map, right? Like trees, as tall as they are or as short as they are. If you don't have any chronic conditions, you're lying. You're at ground level. I can now take a coronal slice through that cube, anywhere I want to slice down through the cube to see the topology of chronic disease. This little, and then we set these up in sectors, which is a machine learning exercise. So they're numbered because they're set up in sectors. We control population density. So this is controlled for population density. Oh my goodness, sector 5, right here. Huge, huge hotspot of chronic disease. Huge. What is it? Diabetes, diabetes, diabetes. This sector right here, this is Uniontown. Diabetes, diabetes, diabetes. We have zip codes in this particular area where over half our members have diabetes. It is a huge burden of diabetes in this particular area. I didn't slice quite far enough down. See this little place right here? That's an interesting little isolated mountain of disease. What's in it? Cancer. Twice the cancer treatment prevalence of any place else is sitting in this little isolated area up here. This is COPD. So what comes out of this is A, we can see the topology of chronic disease, and B, that disease burden varies pretty broadly over a relatively narrow geographic area, which is surprising to me. I didn't understand that that was going to happen. And of course you can tilt it's a cube. You can tilt it and look at the width of the mountain underneath. Here's what we do with it. These are our hospitals, same geographic region. These are our hospitals and those hospitals' catchment area. Let's keep our eye down here on Sector 5. These are other hospitals that are not our hospitals. So you can see, let me go back, Sector 5, we don't have any UPMC-owned hospitals in Sector 5. It's not that there aren't any hospitals there, they're just not UPMC. What happens to us when we're UPMC, it's our member, it's our facility, these are our employed physicians. We have a ton of control over how we incentivize them to deliver care and the resources that they have behind it. These are our primary care physicians. Once again, Sector 5, right here. We have six in the entire Sector 5, which is multiple counties. It's not that there's not primary care physicians there, they are not UPMC employed. So what we do with this is it changes our contracting of how we go out and contract and what do we want the primary care physicians in Sector 5 to do. We want them to ratchet up their diabetes care because that is what's going on in Sector 5. This is lead. This is what I did early on when I came into the health plan. We care a lot about lead poisoning, and particularly in children. It makes them stupid, quite frankly. It decreases their IQ, and it does it forever. I want these kids to grow up, be well-educated, smart, and pay my Social Security. So here's what we did on this. We went through and said, how do we understand where we have lead hotspots? Just use our claims data. Forget the housing age data, all that other stuff. Never mind. We get the lab values. I know which kids have been tested because we get a bill for the testing. I know which kids test positive because we get the lab values. So I use what I call the sentinel child. Find every kid who tested positive lead as an environmental poison, draw a city block circle around it, again, use our latitude and longitude, and find every untested kid in the catchment area and focus our outreach on the untested kids who live close to a kid who has tested positive. This has almost doubled our catchment rate because we have limited resources of what we do. That's Johnstown. There's a lovely little hotspot of lead poisoning in Johnstown, and it sits right along a river. This is the Conemaugh River, right here. We work with the county health departments on this. We share this data with the county health departments to help them understand how to apply their resources to decrease lead poisoning in children. Oh yeah, this is cool. So what we do in insurance land, again I'm using payer billing. In insurance land, one member, one contract number. If you're enrolled in Medicare Advantage, you're enrolled in Medicare Advantage. We see you and you have a distinct contract number. If your husband is enrolled in Medicare Advantage, he has his own contract number and enrollment. The two of you are not connected in any way, shape, or form through anything that a payer does. So we created our own household identifier. So we glued households together. We did it by using our geocoding. And then we did some pieces on the back. We've got about 97% of our households accurately glued together. We have a couple that are a little wacko that we're still working on. So this is what happens. So we glue them together so we know who lives at the same place. And you are insured by us. So this might be a Medicaid insured child who lives with a commercially insured mother in a particular place. So we might have a Medicaid and a commercial person in the same household. Here's what we did with the households, because we want to not manage the member, we want to manage the household. So there's a member, they have attributes, those members map up to households, those households map up to communities. And communities have resources that we want to use to help our members become healthier. Didn't work there. So here's one of the first things we did on this. So the top line at t equals 0, right here, t equals 0. These are 2-member households where somebody died. So this is about the survivor in a household where somebody died. At t equals 0 is the death. This line down here is the survivor's use of emergency room and urgent care. 6 months before the death in the household and 6 months after the death in the household. You can see there are 2 distinct trajectories. 90% almost of our members are doing nothing. The survivor's doing nothing in the emergency room and the urgent clinic and unplanned care, and they're doing nothing after the death in the household. About 10% of our members, however, are already using, the survivors are already high utilizers of what we call unplanned care, emergency room use, admit to the emergency room, or urgent care. And after the death in the household, their use spikes. How do we use this? At a death in the household, I don't need to know anything other than to look backwards at the survivor's use of the emergency room to know which trajectory that person is likely on and where to focus our outreach for people who have had a death in the household. Yes, opioids. This is interesting. So take a look at households, multiple member households, where nobody in the household is holding a script for opioids. That doesn't mean there aren't opioids in the household, friends. It just means nobody is filling a script for opioids. Presentation to the emergency room for an overdose is about 2.2% for people who are in this household. Presentation to the emergency room for an overdose is about 2.2%. Here's a household where somebody is holding a script for opioids. The script holder presents a little over 10% presentation to the ED for an overdose. The non-script holder in the same household presents at 3.5% of overdose for ED. This is highly significant because the numbers are really quite large here. So now we've learned that we need to manage non-script holders who are in households with script holders. We currently have a lot of work around opioid use and opioid, which is both appropriate and inappropriate depending on the case. But now we are focusing on the other people in the household, again, managing to the household. This is the length of treatment. So this part here is therapy, cognitive therapy, plus methadone. This is methadone only. You can see that we get much better results out of therapy. This is where the hot spots are. Let's revisit Sector 5, friends. Right here, we have an opioid hotspot that is dense. Again, adjust it for population. This is the opioid disorders. This is Sector 5. They have almost no treatment centers. I've talked several times to the senators, the state senators who are representing these counties about wanting what they need to do. They have a huge burden of opioids in these counties, and yet they have a lack of treatment centers. The first time I talked to them, here's what they had to say. We don't want treatment centers in our county because we don't want to be known for opioids. Oh, hon, way too late, baby. The ship has left. You need to be known for opioid treatment. Time series is the standard. The past predicts the future. Future looks like the past. Those are the assumptions when you're running time series to predict what's going on, is that the past can predict the future, i.e. you're using time series, and B, that the future looks like the past. As we expand and as the insurance industry changes, the second is no longer true, and we have created our own models here. This is a training model. It uses 24 months of data, 12 months, 12 months, 12 months. It predicts on the oldest 12 months. It looks at its era on the newest 12 months. It corrects for the era, and it predicts for the newest. The best in class that you can buy predictor model runs around an R squared of 0.28, which I know sounds a little lame, but hey, in our business, that's actually quite good. This model runs at a 0.35 because it trains itself each time. Oh, and now I'm going to talk about the hardest problem in healthcare. What did I tell you about the joint thing? What did the doctors say? Oh, yeah, my patients are sicker. The ability to understand how people sort by sickness or chronic disease burden is incredibly hard. Doing risk adjustment is a tough nut to crack. So what we are trying to do here is take and sort people so that they are homogeneous, and now we can risk adjust for it. This is an incredibly hard problem. The industry has not solved it. We've made some inroads. This is why risk adjustment matters. So if this is the average for an episode, so we build episodes. If this is an average, so the average episode for whatever we built here is $2,535. People who have high risk, medium risk, and low risk by our proprietary in-house piece, this is what their costs are: $59, $1,500, and $650. So if you're just using, so the average, the way the industry does this is it picks up a benchmark. It says this is the average episode cost. And then it looks at your episodes, doctor, treatment episodes, compared to this. So now if you look at these are actually out of our data. If you look at this particular physician, their average cost is $3,020. They look pretty inefficient. In fact, their unadjusted efficiency ratio, which is their cost divided by the average cost, is 1.19. Ooh, we don't like that. This guy over here looks great. In fact, she's fabulous. 2023, she's got an efficiency ratio of 0.8. Everybody would be happy with that. The problem is, this doctor actually has sicker patients. So when you adjust for the severity, now look at the efficiency ratios. This is why risk adjustment matters, and if we're going to have value-based payments, we're going to pay people based on the efficiency of what they're doing. We have to do risk adjustment. This is the impact of risk adjustment. This is, across the bottom is their risk score, and here is the per member per month, pharmacy and medical spend. So spend goes up this way, risk goes up this way. We've got an outlier right there. But when you apply our risk adjustment, this outlier moves way over here. This particular clinic, it's a clinic, has far higher risk in the clinic than anybody else. We base our payments to them based on their risk adjusted efficiency. I won't go through that. This is interesting. So we build each person as a vector of their chronic diseases. Once again, back to our vector model. Then we use a fuzzy logic cluster to say, how do people, I want people who look like these people. There are actually 13 natural clusters that come together. We don't constrain that. Most people live down here. Over half of our members are in a cluster where they have no chronic disease burden, thank goodness, because we're in the insurance industry. And 1.3% of our members live up here. This is a really high burden of disease. People can move among these disease states. So this is a Markov model that shows you how people move among the disease states. What we want to do is move people to lower chronic disease burden, not higher chronic disease burden. And on that, these partnerships. So this is what we did. I think we're in our third year now through UPMC Enterprises. UPMC Enterprises is our startup and venture capital. We have about $500 million in play in investing in startups and standing them up and helping them and standing up startups within our own employees' ideas. We made the Pittsburgh Health Data Alliance, which is an alliance between Carnegie Mellon University and the University of Pittsburgh and UPMC. The University of Pittsburgh and UPMC are separate entities. The University of Pittsburgh is just that. UPMC is a large payer-provider system. UPMC, what did UPMC provide? We provided data. We have buckets of it. Buckets and buckets and buckets of data. Free text data, structured data, we have all kinds of data. And money. We put $20 million on the table to pony this up out the gate. What happens? So we provide data, commercial guidance, industry experience, clinical guidance to researchers at Carnegie Mellon and the University of Pittsburgh, they pitch to us. Basically, they present what they want to work on. You don't have to go to NIH, we'll fund you. They put their projects in there, we fund their projects. And then we already have worked out the IP and commercial agreements, so the legal agreements behind the back. Our gig is to commercialize what they are doing. So what we get out of this is we get the intellectual property, we get leading edge researchers, we get lots of super scary smart people working on problems that matter to us, and then we stand up startups off of this, we spin out companies off of this, we do licensing agreements, we use it in our own facilities and doctors, and we provide the business proof of concept of whatever the really good idea is that they had, and we take it to market. And to date, we've had 35 projects over a variety of places. We have 14 of those projects are not just UPMC and Carnegie Mellon or UPMC and Pitt. It's both. So 14 of these projects are people in both sides. An example is this particular company. It was trying to address the case that chemotherapy and immunotherapies cause an inflammatory response in patients. It's a big deal in cancer treatment, quite frankly. And then then you have to do a lot of drugs to try to inhibit the inflammatory response. They stood up a neuromodulation response to this, so that instead of using drugs, you use a neuromodulator on it. And it is a team between UPMC, Carnegie Mellon, and Pitt, using polymer design, electrical engineering, neuroscience, and cancer biology. Here's another project we did. It is physical therapists have to visually monitor patients, so they make sure that they're doing their exercises the correct way. That means that they can't go do something else because they have to sit there and visually monitor them. And when the patients go home, the patients are doing their exercises on their own. You know, we get sloppy when we do things on our own. So the result was these sensor systems that monitor the patients through algorithm feedback. And it is, again, a collaboration between UPMC, Pitt, and Carnegie Mellon University. This is the danger of big data. We have a lot of data, we use a lot of data, it's everywhere. You want to know something? Oh, hon, we'll throw so much data at you, you will ignore us. And then you ask a question, don't worry, we'll rain down more dots of information on you until you finally acquiesce and do this. So if data is going to matter in the industry, we have to serve up what people need, not serve up everything that we can serve up. Herb Simon, wonderful person, was an economist at Carnegie Mellon University. Herb said this in 1971. An information-rich environment creates a scarcity of what it consumes. Think about that. An information-rich environment creates a scarcity of what it consumes. What does information consume? Your attention. And attention is at a limited supply. So our job as analytic experts is to make sure that we don't do this, that we pay attention to that. Thank you. We have almost 3 minutes if somebody has questions. No questions, I give you away. Yes, ma'am.
I really like your analytical analysis behind networks. Given the state of Pennsylvania and its competitive nature in the Medicaid environment, right? Because you have several MCOs. It would have been interesting to see how UPMC compared itself from a high-risk population group with dual eligibles, right? Those in your same network compared to your other products for high deductible plans, that same population group, those who are under Medicaid waiver programs like 1115C, like for long-term care services and supports. Because when you're looking across that, what we find too is that eligibility rules do drive access to care, which changes the way that patients behave in that block. So that was something I was kind of hoping to see, but didn't, because of the environment that the state of Pennsylvania is in, and the competitors in your environment.
Yeah, so clearly you're into the MLTSS world, without a doubt. We do have it, I didn't show it here, and we have models that predict, so to your point, waivers and, what is available to a person changes what they actually consume. It's incredibly important. The MLT, the Medicaid Long-Term Supportive Services Program in the state of Pennsylvania is both insurance, and it's mostly dual eligible, so they're Medicare and Medicaid enrolled, and it is also services within the home, like Eradicate, it's pest control, it's ramps, it's handrails, it's whatever people need in the home to stay in the home. We have a whole series of really lovely models that predict who is nursing home eligible. So the amount of money available for taking care of somebody and the resources changes whether you are nursing home eligible or not. And it's a very complicated, as you know, algorithm of what to do. We predict who is actually nursing home eligible, and then we go and work with those. But it's by line of business, commercial, Medicare, Medicaid, CHIP, SNP, dual eligibles, how they move around among providers and what they do is radically different because the financial incentives and the network available to them is radically different. Yeah?
Thank you, Pamela. That was great. I had 22 questions, but I'm going to restrict myself to just a couple. I liked the presentation of what you were doing with risk adjustment, and I'm curious how you address the issue of bias that is now making headlines everywhere in the machine learning models. And my second question, on the topology map that you laid out, I'm curious if you juxtapose that with sort of the social determinants of health in those areas to figure out what the correlations are.
Yeah, so I'll start with the second one first. Yes, so Sector 5 is also a food desert. It's serious food desert, one, and it doesn't have a food bank. So there are definite pieces around social determinants that we lay over the top of it. I didn't show it to you, but we also download air quality from the air quality sensors in the area, and I can show you a very tight correlation between the use of the emergency room for asthma at where the member lives and the air quality in the neighborhood where they live. The bias issue is really important. The way that we finance, so back again to the MLTSS piece, the way that we finance care biases how people use care. If you're just using unstructured machine learning to go in and say, I'm going to learn what we need to do, you're learning on bias. So if the way that we know what is happening, we don't know what should be happening. So if you're using data to say this is what should happen, no, you're just amplifying bias that sits there. I'll give you a good example of bias. If you have a condition for which the majority of treatment for you occurs on the inpatient setting, not the outpatient setting, you will have a higher financial burden if you are a Medicare fee-for-service enrollee than if you have a condition that is treated primarily in the outpatient space because the deductible, the copay on the inpatient is so high. It's over $1,000 per admission. So there is an inherent bias in the financial burden of disease in this country based on the disease that a person has. Now, if we use our data and just blindly go in and start using machine learning, we're just amplifying, we're not learning anything, we're amplifying the bias. So machine learning allows us to do it fast, but it just allows us to get stupid faster. So you really have to understand the data that you're using and how to use it and how to interpret it. I see Kenyon ready to wrap it up. Okay.
But you have time. You have 5 more minutes.
Oh,
questions.
okay.
We built that in.
I will not be the chooser. You shall be the chooser.
That was a fantastic talk. Thank you for all those examples and learning more about what's going on in your organization. But one thing that I had a question on is that it came up in the first, when you were talking, the first example when you were talking about the hip replacements, I think, and you talked about the resource use. Do you guys do any kind of outcomes to think about whether those low resource use positions are actually doing a good job with their key resources? And then this seems like an important issue in all your analytics.
So there's these things we call patient-reported outcomes, PROs, which are used pretty much across the industry. So we do have them. They're a little more difficult to use because they're unstructured data. I didn't talk about it today. We have an NLP, we have two actually, NLP, natural language processing, engines that we own at UPMC and deploy and to run across the top of the electronic medical record. We call it Abstraction Genie, to go out and pull these pieces in. So to this point, they have better patient-reported outcomes, the group that has the type protocol. And as I showed you, the outcome of interest, we looked at two outcomes of interest there. One was infection rates, post-discharge infection. They have almost none, nor does anybody else, by the way. And the other was readmission. And that's where you really see the difference in if you think of readmission as a failed discharge, which is what we call it, that is the clinical outcome of interest that we look at.
Looking at your risk adjustment.
It's a hard problem.
You try to analyze data in terms of diagnoses and ancillary testing.
Yes.
And try to come up with acuity levels that you can use to measure the clinical resources that would potentially be consumed by the patient.
Yes, and this is let me tell you why this is such a hard problem and why it's not cracked in the industry to date. So if you want a problem to work on, this is the problem. The downside is you will need buckets of data, and it's proprietary data, so you have to go make friends with a big payer or provider somewhere. The piece here is, in the industry, overwhelmingly what they're looking at is money. Money is a function of contracting. What we pay a provider is a network contract. It's not a uniform. So if we pay an academic medical center a higher rate for something than we pay a different medical center, that doctor who works at the academic medical center is going to be more expensive. Has nothing to do with the doctor's quality, the care, the utilization, or anything else. It is a contracting problem. So you have to flatten the money, one, in order to get at the quality. Two, in the industry, the way risk adjustment is done is almost always around money. The way we risk adjust doesn't have money in it. So we're not using money to risk adjust. We're using your chronic condition burden to risk adjust. Those 13 clusters of people like me with a chronic disease burden, that is the basis of our risk adjustment. It's why it is so different than what is going on in the industry. We don't use money. The second part is, you can't tell from a risk adjustment perspective. All you can see is what has happened. So you could have a provider who's very expensive. They use a lot of something. Is that good care or bad care? You need clinical outcomes on the back side to answer that question. And we built our own little variable. We do lots of things. I like to call it momentum. So it is velocity times mass, which is why I call it momentum, of course, which is not how many echoes did you do, how many stents did you put in, how many something did you do. I don't know what the right number is. I'm an economist, for Christ's sakes. What I do is I use the relative value units, which is how MedPAC sets Medicare reimbursement fees. So MedPAC is setting the actual allowed amounts from Medicare fee-for-service based on relative value units. So each service has a relative value unit, which is supposed to capture how much resources are needed to deliver that service. So how many resources are needed to deliver an MRI? So Medicare sets that out, and then they base their fee schedule on it. I grab the relative value units. So here's all the services that were delivered to Susie Sunshine for her whatever, right? I don't care if you did a PET scan and 1 outpatient visit or 88 outpatient visits. I'm not making any judgment on that. I'm just saying, in total, how many relative value units did you use to take care of this patient? And then I look at the velocity at which you are using them. Is this a smooth, or do you do this? And off of that, I make this variable called momentum. Now I want to know which providers have the lowest momentum around patients who have a clinical profile of group 8. So these patients have a similar clinical profile. Which doctors are the best at taking care of type 8 patients? That's what I want to know. So one of our clinical profiles is driven by serious mental illness. Each one of the profiles has a dominant something in it. Not everybody with serious mental illness is in that profile because it's a fuzzy logic. You could live in, diabetes is probably present in all but the lowest profiles. Now I want the ultimate, the actual holy grail here is for people who look like this clinically, this is their clinical burden, which providers do the best job of taking care of people who look like this? So if I've got type 8 patients, whatever their clinical profile is, which providers have the lowest momentum to take care of type 8 patients while maintaining their quality outcomes? That is a match right. Here's a provider who does a great job of patients who have serious mental illness and high comorbidity. I want to now pay the provider based on that complexity. So rather than just pay you whatever I pay you as an outpatient physician, I want to pay you based on the complexity of the patients that you are treating. Because you might not want to come in the morning and see your waiting room full of Medicaid or SNP members who have schizophrenia. Holy schmoly, how's that for a day at the office? Because every one of those patients is going to take 45 minutes. And you've got them all booked for a 15-minute appointment. You'll be there at midnight. I want to actually pay you based on the complexity of the patients that you are seeing. That is what I think of as value-based reimbursement. And I want to make sure that you are paid adequately for the complexity of patients that you are seeing. Yeah. Can we take last question? Last question.
Thank you very much. This is very exciting to hear about your talk and see the graphs that you posted. My
That's what I
question.
love about this place. Nobody else would think this stuff is exciting.
Oh, this is amazing. And I always wanted to be taller until I saw your chronic disease map. I'm happy with how it looks. So I just wanted to know, when you have these findings, such as the lead project, how does the loop close there? How does it get back into the workflow of provider-patient?
So the lead piece is an interesting piece. We share that with the county health department. So the county health department has now changed its direction and focus on how it is dealing with lead poisoning in the county. And two, we share it back with the pediatricians. These are children. So that we provide for every one of our pediatric practices the list of their sentinel kids. These are the kids that are in your practice, doctor, that have not had a lead screening and they live in the catchment area of a kid who tests positive, so that we are helping our physicians actually focus. We want them to test all the kids, but actually focus. Susie Snowflake, ding, 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 ding. She lives near a kid who tested positive, and she has not had a lead test. So we try to change practice by feeding that data directly into our providers. Thank you very much. You're a wonderful audience.
Well, thank you, Dr. Peele. That was a terrific way to kick off CHITA. I think it really shows how data is being applied at the front lines of care, being able to identify these areas that need support. So thank you again.
Thank you.
I hope you can stick around for a bit.
Yes, I'll be around this morning. Yeah.
Okay.
So, and again, thank you all. It's a pleasure to be in a room that's so intellectually dense and smart. And
Some of us more dense than others.
And people who actually, this stuff really is exciting, who actually realize that this is how we are going to change healthcare in this country, is off of data. But we have to be mighty careful about what we say we should be doing based on what we were doing. Thank you again.